Welcome back to the Demanding Value Podcast, where we dissect both sides of the buyer-seller value equation so everybody wins. The last episode, we had Mina Medler, Vice President of Strategic Supplier Engagement for Premier, where we talked all things value-based care, risk-share agreements to make sure that there's a true partnership between the end user and the supplier. So she gave us so much great information that I wanted to reach out with a vendor that has actually successfully engaged in value-based agreements, and that person is John Maverick. John is the Director of National Accounts for Teleflex Medical, a $20 billion healthcare manufacturing company that has successfully implemented value-based agreements consistently with the right customers. And that's what I wanted to dive into with him. How do you understand who's ready for a value-based agreement? What are the do's and don'ts? How do you make them work? What are the watch-outs? How do you track the data? How do you put the legalese together? So we went into all of that, and John was just a pleasure to talk to, a great guy. So without further ado, let's get to our conversation with John Maverick. Let me just do a brief introduction for you, and then you can kind of fill in any gaps that I missed. So, John, you are the National Accounts Director for Teleflex, and you've been doing that for 9 years. Prior to that, you were with Bard for 9 years, leading sales teams. So you have a vast amount of experience in the medical device, healthcare sales world, selling to hospitals your entire career. And Teleflex is a massive company. So $20 billion market cap. I looked yesterday, the stock price was at $440 a share, which increased 173% over the last 5 years. I mean, it's pretty amazing. And Teleflex is all over the hospital in anesthesia, ER, interventional cardiology and radiology, interventional urology, respiratory, surgical, urology, vascular access. I mean, like, oh my God, like they're everywhere. So you really are the perfect person for me to talk to about value-based care because you offer value throughout the entire hospital. So it's truly amazing. And one point that I want to make out right on Teleflex's website are these three statistics that say 90% of hospitalized patients receive some sort of vascular access device, number one. Number two, 768 hospitals were penalized in 2017 due to poor performance related to hospital-acquired conditions. And then three, penalties related to those conditions scores totaled approximately $364 million. So Teleflex is directly focused on avoiding problems that cost money, right? And of course, for clinical impact. So sorry for the very, very long introduction there, but you're up to some really impressive stuff. And I want the audience to understand who you are and the space you're operating in. So thanks for being here.
You got it. And I appreciate being on. This is an area that the best word to suggest it is passion for me. And I know for several folks that are in the vascular division, it started out of a need because we were facing a big dominant market share leader. We're second in a market that's 98% led by the market share leader. And they created the actual market. They were the ones that went out and developed the actual clinicians that have now started putting these types of products in the vascular space. So we needed a different tool in our tool bag, in addition to all the things that you typically do with your sales teams. And the thing that I want to impart upon the audience is don't let this seem too complicated. Don't get overwhelmed with how do we create something like this. We literally sat down in a conference room with the VP of sales and the president of the company, the division at the time, and we worked it out on a piece of paper. Really? And then gave it to the legal department. So, one of my favorite vice presidents in the past always used to say to me when I was early in my career, the difference between me and a lot of other people is I try it. And I think there's a lot to be said for that, right?
Yeah.
Too often we get paralyzed with development. And I know we all operate in this space in a very legal, regulatory environment. And it's important that we're protecting our shareholders and we're doing the right things. But just figure out how to operate within the confines of that and do it.
Yeah.
So that was how it started. And it very simply was, we sat down and we literally whiteboarded it out and wrote it on a piece of paper and handed it off to the lawyers and said, can you help us? So back in those days, The word risk sharing was being bounced around all over the market. Everybody, everywhere you went, every conference you went to, you know, every single one of the magazines had an article about risk sharing in it.
Yeah.
And what we soon found out was that the market really didn't understand what that was, really. And we went out and started talking risk sharing, risk sharing, risk sharing. And we soon understood that we weren't really risk sharing in the sense that it's really more of a payer model in the risk sharing world, right? We weren't going to be remunerated for the risk that we were able to drop, right? So we changed the terminology to risk mitigation. So we went in saying, we're going to drop your risk with our program, with our product, and the benefit of it will be this. And that seemed to work a little bit better. But also, as you mentioned, the statistics, being in the vascular space, we benefit from the fact that the government is involved in this now. They are requiring hospitals to track these hospital-acquired infections, and they're penalizing for it. The next thing that we learned was that you don't want to create a program around a soft cost. A lot of people like to get into the soft things like length of stay. It needs to be something that the hospital can put an actual number to. And in that learning lesson, what we found was we would go in and start talking about these hospital-acquired infections. Number one, the hospital wasn't that up to speed on that program to begin with. You'd be surprised, even meeting with the C-level folks, they were just getting into it. They just started to understand it. They hadn't been penalized yet when we started. Their first penalties hadn't been handed down. And the other thing was that we soon learned is that they not always understood what it actually cost them, the actual infection, the actual problem. It might not be an infection for some of your listeners. It could be other different things that it affects on the outcome side, but they didn't understand the actual dollar value. How much does this cost your hospital when this happens? So we had to sit down with finance people and they would put a pencil to it. And they actually would come up with a number. And we always tried to use their numbers, not our numbers, even though there's market statistics and lots of surveys, and you can read different articles on whatever your outcome is. You'll find one that tells you it costs this much. But we always let them use their number. Because then, again, it's building trust in the model. Because this was a new idea. Nobody in our space in particular had walked in and said, we're going to guarantee you a certain kind of an outcome if you use this product. And if not, here's the reward for that.
Yeah.
And so we learned very quickly, they don't know. And you have to start that. You have to get them to identify it so that they can understand their own pain.
Yeah.
Once that had happened, the next thing that we ran into, and this is the oldest lesson in sales school, if you don't have the clinical support for the idea, it doesn't matter.
Yeah.
That these types of programs are not supply chain programs. If you go to supply chain and you start talking to the supply chain people about, I'm going to save you $350,000 to the bottom line, hard dollars, but you're going to pay more for the supply, it's a no starter. Yeah. They won't even take it to the value analysis committee. They don't want to hear that.
Right.
It's not something you can start in supply chain. You have to have everybody knows it in device. You've got to have the clinical champions that are willing to try it and fight for it. Then you can bring the value of the total program to the hospital. And that was a challenge because now you're linking together supply chain with clinical outcomes. They don't really care. They care, but they don't get incentivized on clinical outcomes, at least that many years ago. And it's still mostly true today. They're incentivized on reducing price, right? Mm-hmm. Saving supply chain money. And then you're pulling in clinical folks that don't understand the business of it. And you're trying to link the two together. And especially when you're up against a market leader, even with a great program like this, it's a battle, but you have to put the two together.
Yeah.
And since that time, the nomenclature has evolved to value-based or performance-based contracting.
Okay.
And that's really a more accurate description of what we do. We've done two different types of programs. One is we'll go in and we'll take a look at what their outcome is, at their baseline outcome. For instance, a number of infections.
Yep.
And we'll measure against that base and tell them, and we've done this, we did this for a big system, thinking of one out on the East Coast. We'll guarantee you that we're going to reduce your infections to blank, a certain number. And for every infection we don't get you to, we owe you some money back because you had to pay for that infection. So there was a guarantee for them to get to a certain number. The other way we've done it is we've simply gone in and said, look, what's your baseline infection rate? And these are for the accounts that are not that skilled at knowing what they need to know. We will guarantee, what we'll do is match the price on the product that you're currently using. So you have really no financial risk.
Yeah.
The risk is time. It's a time investment, which is costly. Time costs money. But we will guarantee that no matter what the outcome is at the end of this trial, if you will, we're going to rebate you back the money that you spent on our supply over the current supply cost you have. We had success with that on accounts. I think of one out on the West Coast, big system.
Now, John, was that dependent on the lowering of infection rates, or you just said we're going to eliminate the increase in cost flat out?
The latter. So we just make it very simple and say we're going to eliminate the cost of the supply. Essentially, you're trying it for your time.
Got it.
So you're not going to spend any more. Supply chain likes that because it's not an increase in their cost unless they start buying the product afterwards forever. And then the clinicians like it because they get to do the trial, and it's simple. So it's just a very easy way to go in and say, try it. Financial risk is out, and we know you're going to get a good outcome. We do track those outcomes. We'll get to that in a second along the way. So those are the two basic types of programs that we've done, and it's evolved from the term risk sharing to performance or value-based contracting. And the fundamentals of it are, again, you've got to link together your clinical champion, very important, and the account must know the pain. They must understand the cost of the pain to them, and it cannot be soft cost. The soft costs are no-goes. Yeah. Everybody likes to say, I dropped 3 days of stay off of your patient stay. Well, how do you really know that, right?
Yeah.
So we happen to be blessed in the fact that we're operating in our space in a place where it is tracked. They are required to track that outcome. They're required to report it to the government. So any of you out there listening that have that luxury of my technology directly impacts something they are tracking, you've got to go for it, because a big part of your challenge is over with.
Yeah.
It's already done for you. The next part of it is some of the learning lessons that we had was not often are the accounts that you think really need this, that are in the worst shape, can handle it. They're in bad shape for a reason.
Okay.
Right? They might not have the best processes and policies, and that's why they're in bad shape. Maybe they don't have the right personnel to drive them to the goal that they need to get to. And you can take a program like this inside there and go for the biggest one and think this is going to be great for us. It's a revenue generator. And, we all have a sales quota when you're in sales, right? And they just can't handle it. They're not able to track it well. They don't know what it costs them. They don't have the right policies for use of a different kind of a product. They don't implement well. Their education's poor, all kinds of different excuses. But we found that often you don't go for the ones that seem to be the ones that need it the most. You look for those that are the most ready. Now, there are some surveys out there you can Google that have been done, readiness surveys on this kind of thing. And it is oftentimes the mid-level hospital that's well run that may not even have a really high problem with your outcome, but even if they reduce 1 or 2 or 10%, they want to do that because they're just all about getting that improved outcome. They're about being efficient, right? So that's the thing that we learned early on, was doing the type of surveying and questioning and meeting that we needed to have with that account to determine, should we walk away on this one? They're probably not ready to even do a program like this. And that's hard, right? Because in the sales world, you want to win them all.
Oh, yeah.
And that's a hard thing to do, but it is absolutely a game changer when you do that, because then you get so many other learning lessons and accounts that are ready. You can share those with the others. You can teach them. You can link them together. They can speak to each other.
Yeah.
And so that was a big learning lesson for us too, was to try to find places that were really ready, that had the right personnel policies, procedures, were well run, they had good analysts.
John,
And then,
is there like a litmus test that, you know what, if they have an answer to this question, they're probably ready, or vice versa?
yeah, I think I've gotten to the point where I think the litmus test is if they can tell you what it costs them to have that problem, they can tell you the dollar figure, that means they've done their homework.
Got it.
Because they would have had to track it, they would have had to pull the issue, they would have had to take it to finance, they would have had to pull the master chart and figure out all the costs. If they know the cost and the number of problems they're having, that's a pretty good sign that they know what they're doing.
Got it. Now, in regards to cost, you made a fantastic point a little bit earlier. I just wanted to dig into a little bit that you mentioned that you use their number for cost. So you sit down with finance or their accounting folks to understand how are they putting a cost to this. So how do you get to those folks?
So a few ways. One is, oddly enough, and the most basic way to answer the question is, if you've never literally walked into a finance department in a hospital, all their cards are out front. I mean,
Yeah,
I hate to say it be that simple. I know finance isn't typically a department that a lot of us call upon, so there is some uneasiness there. But you can typically go in and their cards literally are sitting in the front of their office. That's number
yeah,
one. Number two is they'll use in our clinical champions. So we could go to our clinical champion. In our case, a lot of times it's the infection preventionist in this world. They they will know who they are, and if they're a good hospital, that person already knows the cost. They've worked it out for you.
yeah.
You're not having to go do the homework for them. But when they haven't done the homework, they usually know who that person is because typically now on these value analysis teams, there's a representative from finance on the value analysis team, a director of finance, not usually the CFO, but somebody below that person, and they can connect you with them, or they'll get it for themselves because they want to learn it.
Got it. Got it. Okay. Do most hospitals have an infection preventivist?
They do.
Is that
Most
right?
do.
Okay. Got it.
Yep. And the newest branch of that, it's not really a branch, but it's becoming more prevalent, is quality officers are becoming
Got it.
very, very prevalent. So you're going to have, in our world, you're going to have either a quality person and or an infection preventionist. Those will be the folks that are directly assigned with linking their reporting to the government on our particular issue.
Got it. So, John, the sales process, what I'm hearing from you has not changed. You're still going to the demanding surgeon or clinician or whoever your champion is. You're making sure that they really want to get this product in their hands and that they're willing to fight for it. So, am I correct that your value-based program, your willingness to assign risk to what you're offering, is ammunition for that demanding physician to get it through? The program in and of itself will not get it through. It's going to help your demanding physician get it through when they really want it.
Absolutely, 100%.
Got it. And then when you're doing that and that person is demanding it and they don't know the cost of an infection, you're trying to use maybe some evidence to do it. At that point, is that when you're sharpening your pencil with their finance person to say, okay, let's update these numbers. Let's make sure that we're all on the same page with what a cost of infection is. And now what I'm hearing is you're developing a partnership with them. You're kind of working on a
Yes.
document together. Is that accurate?
That is accurate, and that's, obviously you're signing a contract with them, so you have to get into that level of detail and research with them. But absolutely, that's when that happens.
Got it. Now, John, you're in the world of preventing infections and lowering infection rates. So, how do you, in a value-based agreement or a risk share or risk mitigation agreement, attribute the infection to the product or not to the product? Because that's a question that comes up all the time. Was it the product? Was it something else? Or maybe you did lower infection, and the hospital saying, "Yeah, but that's not really the product that did that." How does that play itself out?
So we understand there's in this area there is a significant amount of CDC guideline and recommendation from various associations like the Infusion Nurses Society, et cetera, that lay out the best practices to help reduce these problems. It's not any one thing, and you're absolutely right. We always tell our folks, this is not about a silver bullet. This is about adding an additional tool to your comprehensive program. So the thing we start with is in our due diligence, have they already implemented the other things? You know, in our world, have they implemented the bundle, for example? Are they already doing that? What does their insertion practice look like? You know, what are the different things they're using that are recommended by the different regulatory bodies? Once they're doing all of those other things and their education is up to speed, and we have education as well, then it's more palpable that we're adding on one more thing. So that's the world we operate in. As we look back at a snapshot in time, and we get a baseline where they've been doing all of those other things for a certain number of months or a year, and we add in the one more thing, and then we measure it against that. Now, will you ever get somebody say that was 100% the reason that it happened? No, but if you've done that level of setup and partnership conversation with the hospital, they'll look at it and realize there was really maybe only one other major factor, and infections were reduced by this amount. So adding that into the fray definitely helped us. It didn't hurt us, so why wouldn't we keep doing it?
So John, so I asked earlier about a litmus test. How do you know if a hospital is ready to partner? So by going over those other recommended guidelines, the best practice guidelines, and which ones have you already implemented? Am I correct? That's another litmus test if they've done some of those other things.
It is, and we always start these with a clinical assessment. So we have a team of clinical education, clinical sales managers, and they will go in once an account says we're interested, we think we're interested. They'll go in and do a pre-assessment, and they'll get up on the floors. They'll talk to the nurses and the doctors that are doing the procedures. They'll watch their practices. They'll review their policies, and then we'll come back and make recommendations. And sometimes they're not ready to go, so we'll help them with some of those other things. And again, like I was saying earlier, get them to a place where we know this is a good investment versus this is not a good investment yet. There's been times where we've done the assessment and said, we'll come back in 6 months. Here's what you should do, but we'll come back in 6 months.
Yeah.
So we always do that initial assessment. And during that time, as everybody listening that's in sales knows, you're building a relationship, right?
Yeah.
You're showing more value than just here's my widget and it costs this much and you can buy some and it's on contract. So we generate a lot of goodwill in that, and we help them a lot.
Yeah. Has your willingness to establish a risk mitigation, value-based program, performance-based program, has that been a differentiator for you in the market? Has it been really a way to say, hey, we're really a partner, and has it helped you grow your business?
The answer is yes. It's a slow burn. It's a slow burn. We are the only one in our space that offers it. The market leader doesn't feel like they need to, which is fine. They don't. I mean, they have most of the market, right?
Yeah.
And I think right now, the best comment probably from the sales team would be, I use it in conversation. It's a differentiator. And a lot of times the account, after they hear the entire story, will say, we don't even need to do that. We think your technology sounds pretty good.
Yeah.
And some accounts will say, we need to do that. We'd like to try that. So it's been one of those tools that the reps and the managers can pull out of their pocket when they feel like they need to have another tool.
Okay.
We don't lead with it, and there's many times we never even mention it because the account is just going that well.
Yeah.
We don't have to bring it up. They buy into what we're telling them. They buy into the clinical evidence.
So John, you have I went over your depths of experience in this space. I mean, it's significant. So you have a feel for the industry, where it's been and where it's going. Do you feel that value-based care? I know risk share was something everyone was talking about. People didn't understand what it meant. Now, do you feel like this is where the industry is moving more and more, or are we still in that? Yeah, people talk about it, but they're still not willing to pull the trigger most of the time.
I think, and everybody out there, do some research on the internet. You'll find lots of great articles on this. It is the movement. It's where it's moving. It's going to go this way. There was in one of the readiness surveys you can get to online by one of the GPOs, I believe it was 83% of C-level folks said, we're interested in doing these programs. I think the reason that they stated they hadn't done it is because nobody's talking to them about them. Shockingly, right?
Yeah,
So I think that it is going to be, with every dollar being squeezed out of healthcare and everything that's going on, especially with what we just all went through in this last year, they're looking for other ways to guarantee their financial and clinical future.
that's right. Yes. So how about, do you have any, you talked all, we before the meeting today, we said, okay, let's talk about some do's and some don'ts. What are some don'ts that you've learned?
So do not lead with this with supply chain. We talked about that.
Yeah.
It's a dead deal. They don't want to hear about it. It costs how much more? No thanks. Uh, do not overcomplicate it. We started it out in our original document. We put so much in it. We put 3 different types of things we could measure outcomes on. It was probably a 9-page document. And just keep it simple. Do not overcomplicate it. Just make sure you put what you need in the fewest amount of pages that you need to do it in. Do not always go for your biggest customer when you're getting started, because you can really screw it up if you haven't learned a few things.
Yeah.
Go out and get some experience, get some war wounds first, and then bring it into your most valuable customers.
Okay.
You're going to need to understand the where you're going to trip and fall down, and it's going to happen a lot. Do not assume that the people you're dealing with in the hospital, all the way up to the administration level, might not even really understand the impact of what the problem is you're solving.
Right.
Even though it's tracked by the government, in our case, they don't get it a lot of times. They're not sure. Shockingly, you would think they would know. They just don't. Especially in the world of the Affordable Care Act, where they're doing the penalties, and lots of your folks listening out there have things that are affected by COTI, for example. That's one of the areas, right? Don't assume that they even understand the Affordable Care Act, of the value-based purchasing impact on their hospital, or even how it works, especially the clinicians. Now, I'm finding the administration level people, they're getting it because it's been out for a while, but the clinicians still kind of push off on that. That's not my world. I take care of people. I don't need to worry about that. I'm going to let the people on the carpet level floor,
Yeah.
do that. Those are probably the major don'ts.
Okay. So the sales process doesn't change. You're still going to your clinician and your user. You're giving them the ammunition when it's appropriate. But you say supply chain really still cares about the cost of the product versus what it's reducing. So who does care? We talked about the infection preventivist. We talked about the chief outcomes. No, there was another person.
Quality officer.
The quality officer. How about the CFO, the COO? In other words, when you're talking value-based contracting, risk share, you think it's a fit, and you have that demanding clinician that wants the product, who are the people that really you would say should be getting involved? Because they're probably a call point that is not typical to
Right.
most sales reps out there. What are those additional call points that these programs bring in?
So in particular, I think we've got to be better in finance. Finance cares 100% about the bottom line. And these types of programs typically are probably going to affect the overall balance sheet, right? They're going to hit the P&L. And that's what the people in finance get measured on. That's what they're bonused on, right? They get paid for, let's increase the bottom line.
Yeah.
So if you can get in there and go to a finance individual and whatever the numbers are you've done your homework on in the beginning, and we always have an idea of what it's going to look like, even before we put the pencil to paper with the account. You get in there and tell them, hey, would it matter to you if I legitimately saved you $300,000 of hard cost? They always look back and go, well, of course.
Yeah.
Of course it is. So I think that we're going to typically find that that's going to be a call point that's going to be more and more important. I'm also seeing recently, in the last couple of years, that finally the compensation plans for supply chain are beginning to change. They're beginning to link the leadership in supply chain to patient outcomes and not just squeezing every nickel out of the cost.
Yeah.
Because they see, there's a lot of spaces where they're never going to supply cost save and get where they need to get, right?
Yeah.
To get the value. So they've got to get better patient outcomes. So I'm slowly seeing that that's happening where they care and they're getting paid on it.
Right. So we'll play our demanding value podcast segment here of Ask Me About. So your suggestion was, hey Gary, ask me about the supply chain director that is compensated directly for value-based care. So I'm asking, tell me about that one.
So in meeting with an unnamed system,
Sure.
had the vice president of materials management one-on-one meeting, had worked out all the dollars with finance, had the clinical support, and sat down and showed this particular individual that we were at the time, it was $385,000 on the low side.
Okay.
It was up to close to $1 million. It's going to be somewhere in between there, but on the low side, even if we just barely pulled anything off, it'd be $385,000.
And that savings, John, was based on infection reduction, the cost of an infection and treating it, and penalties, and it's using their numbers.
Yes, using their numbers, and this is what the finance people had determined would drop to the bottom line.
Got
it. And so, but to get there, they had to spend an extra $62,000 in supply cost.
For your product, because it's more expensive.
Because it's more expensive than the one they're using. So he's sitting across from me, and we go through the entire conversation, great conversation. He's looking at all the numbers, and he said, most people will call me Mav once they get to know me. He said, Mav, he goes, I got to be honest. He goes, I can't do this. And I kind of sat back in my chair. I was shocked. I said, how can you not do this? He said, I'm just going to be very frank with you. He goes, I don't get bonused on what the hospital makes. I get bonused on how much I drop the supply costs in the hospital. Yeah. My bonus is going to get cut. So I'm spending $62,000 more. Yeah. And I said, frankly, thank you for being very honest with me.
That's the problem we're dealing with.
That's the problem. So he was a no vote. Now the finance trumped him, and what they did, and here's a learning lesson I had in that scenario. Finance was able to do some dollar shifting for him. So they said, look, that's ridiculous. We understand the situation. They just did a $62,000 shift on his budget.
I see. Okay.
So he was not penalized for in what he contributed in saving the hospital almost, it ended up being almost $600,000.
So many lessons right there. Number one, that's the problem that we're dealing with. That is a pervasive problem, but I'm seeing it's starting to chip away. More and more supply chain folks are compensated on these value-based agreements, number one. But the fact that you had prior to this meeting engaged finance gave you that other lever to say, hey, let's bring these folks together, right? And now I would imagine, have you run into that problem again and said, hey, maybe we could shift some dollars? Have you sort of used that experience?
No one's been that honest with me since then. But knowing that has to be what they're thinking, I've made that suggestion in later conversations where we will just flat admit, now you're going to spend an extra blank to get there. We know that probably has an impact on your budget and the ramifications of your budget. Yeah. So, and then we'll share the story. One of the things we've seen happen is you just get a budget shift on your budget from finance, because they're going to approve saving hundreds of thousands of dollars for less than 100,000 spent.
To me, John, that is the one of the immense values of doing these partnerships, these arrangements, because it is a partnership and you're dealing with more people, more call points, frankly, at a higher level that enables you to bring in those folks and have that kind of an impact. Because the bottom line is this is helping patients. And by you doing that, you're enabling patients to have access to these products that's going to lower infection. It has to happen.
Exactly. And I think the other thing too, in this space, there was, in the beginning of my days here, there was a buzz phrase, which was zero complications, right? They wanted to get to zero, want to get to zero, want to get to zero. Zero is hard to get to, and it's even harder to stay at. You can get to zero, but it's very hard to stay at zero, right? Well, along the way, some settling starts to happen. And you start to deal with systems that say, well, we don't really have a problem. Well, you had 25 of these last year in your 3-hospital system. Yeah, but that's not as bad as some because they get measured against, they get
Right.
benchmarked, right? And I've started to retort that with what happened to wanting to get to zero. And I was in a value analysis committee meeting, and that came up, and the person said, "Well, we only had blank number of infections," and I said, respectfully, I hope it's not one of our family members.
That's a great point.
You have to be careful about that, but it's the
Yeah.
truth. It
Yeah.
takes it back to the people like, that's true. I know we only have five, but I wouldn't want one of those five to be a parent or a sibling.
Right.
And I think we have to keep reminding, it's so difficult. They have such a difficult job. We have to keep reminding them we're here to help you get there.
Yeah.
And we have some systems that have been able to achieve zero and stay at it. And it's hard, but they can
Yeah.
do it.
So, John, the legalese that came up a couple times when you were talking about this. If it's truly a risk share value based agreement, risk mitigation, whatever it is, there's a contract surrounding it. So,
Yeah.
has that been particularly problematic, or have you and any do's and don'ts with getting the legal framework outlined and done?
Well, obviously, you've got to involve your regulatory and your legal people early and often. And obviously, you're going to stick to what's in your IFU. You're not going to be able to link things into an outcome-based regime that you can't claim, and we don't do that.
Right.
Uh, but you have to work with them to figure out ways that you can put it together a program that is incentivizing enough to the account um, without putting yourself in jeopardy, right? It can be done, and I think one of the don'ts is don't get too hung up on that. Just work hard with them.
Yeah.
You've got the right people. They'll figure it out. They'll figure out how to put something down on paper that allows you to do this
Okay.
in a way that is compliant and is not difficult to understand and can be very simple.
Yeah.
But yeah, we have two types of contracts, and we have one for a certain set of products and one for another set of products because of that reason. One set of products can make claims, the other one can't make, so we have to use a different contract.
Got it. Now, how about, so you're looking to reduce infection using that? That's a really good example. So what if their patient population changes in terms of the volume of patients? Is it a percent of admitted patients, or is it a raw number that you use?
Yep, and the one where we do the tracking of the actual infection, the actual guarantee, it's a number of infections. And the reason that we can get away with the number is because it's not like they have 100 of these a year. Now there actually are some systems that have 100 a year, but they're typically going to have a pretty well-defined number of these if they're going to have them. So if they're on the low single digit side, they're probably not going to go over like a 20, for example. So it's you can easily work out, and we let that evolve with the account. So we'll start with, you have X number, and we'll guarantee up to X number, and we'll reduce to X number. So we work with them to get to the median on it, and then we work out both.
Okay. So
Yeah.
you established kind of buckets, a bit of a range within
Yeah.
the agreement.
In our particular space, they do measure actual events, so it's easier to say a certain number versus a percent.
Yeah. How do you get the reporting? Who is tracking it? Is it do you use the government's data? Do you extract from the EMR? Do your sales reps track it? How is the tracking done?
So all of those things happen. So in the early days of it, when we're approaching an account, it's all public. You can pull the public data. Now that data is aged, right?
Right.
It's 1 to 2 years old. So we're able to at least get an idea and know they've got a problem. Then we get in there and start having the conversation, and we will bring up the government data. They know it's out there. So we're not calling their baby ugly. They understand it. And typically it's not accurate to the present day, right? It's either worse or it's better.
Yeah.
Typically it's a little better, because if they had a problem, they're really trying to fix it, which also shows you that thing we talked about, which is they're doing all the other things to bring it down. So they are doing the other suggestions. Obviously they're not using our product yet, but they're probably doing the other things. And then once we develop that relationship with, and it's, in our instance, it's usually the infection preventionist. He or she is getting the data. She's having their analysts who go in, from the EMR, pull it from the data, pull all the patient charts, figure it out, and they'll know the number that they have going on in the present day.
Okay.
And then they're also the ones we'll work with to establish the baseline. So we'll either go back a certain number of months prior to the start of the review of the technology, or we'll go back to that snapshot last year. We let them pick. Doesn't matter to us. But they'll be the ones working with the analysts in the hospital. And so you go in with the government, you end up getting their data if they're good, and they're ready if they've got it, and then you use their data.
And then how about once they're using your product, is it that same person that is just getting it however they get it, whether it's from their EMR or the infection preventivist? Like everyone has their own way of pulling data, and you're working with someone who's on it that can pull the data. Is that right?
Yes, exactly. Well, it's typically the same. It's consistent. It's usually the same person or people to pull it.
John, have you ever worked with like maybe a community-based hospital? They're not that IT focused, and they just can't pull the data, and they say, you know what, can your sales rep do the tracking? Can your sales rep follow up a week or a month afterwards, talk to the clinician, hey, how's that patient doing? And kind of old school, have a form that they fill out, and then they're collecting forms and submit it. I mean, that is the most basic way to do it, but has it ever gone to that level? Or if you're doing a risk share, no, it really needs to be officially tracked from the hospital themselves.
It needs to be officially tracked. You don't want to get to the end of this and them have the feeling that you manipulated something.
Yeah.
And I'm not saying that reps manipulate data, but they could have the idea that it could have happened.
Sure.
And then it's not only, and it's also complicated by the fact that we can't look at the chart anyway, right? So we actually can't physically do a chart review. So where it has happened, the rep may be interviewing the people on the floor, and the charge nurse or the director of ICU, for example, they'll know. We'll be able to say, hey, keep track of the infections. They know the 3 or 4 they have in the unit, and they'll keep track of that. But you need the account if the account's not willing to figure that out, they're probably not ready.
Yeah, exactly. Another litmus test.
Because that is the key. You've got to track the outcomes. You have to have trust at the end of it, that it was tracked well and that they believe the numbers.
Yeah.
So I would say try to stay away from any account that won't invest the time to actually do the tracking the right way.
Yeah. John, does Teleflex have a term for this? Because we've bantered around a few terms now: value-based contracting, risk share contracting, risk mitigation, performance-based agreements. Like, is there a name that you use or even that you would suggest?
We've recently been using value-based contracting, and that was influenced by a GPO that we worked with that started calling it that.
Yeah.
In fact, they developed a program around it. Then they call it value-based contracting. I'd like the performance-based contracting term, because it's maybe even a little more, it depends on who you're talking to. If you're probably talking to somebody that's goal-oriented, like a numbers person and that kind of thing, or somebody counting something, performance-based seems right.
Yeah.
If you're talking to a clinician, value-based seems right. But I think you couldn't go wrong with either one of those kind of things. What we definitely got away from is the term risk sharing. It just doesn't resonate.
Got it.
It's risk sharing. That term nomenclature is really used more in the insurance payer environment, where you're sharing risk on pay, and it's not applicable, I think, in the device world.
Got it. So it's not resonating with your customers when you bring up risk share, but value-based is resonating.
They get it. They know you're trying to do something to generate a value, and that's what the contract will be based upon. And it could be a lot. It could be the cost. It could be the outcome. It could be a lot of different things. But
so, John, let's talk about timing of engaging the key stakeholders. So you're selling to your clinician or your ideal end user. Finance needs to get involved, or one of the other high level folks that we talked about. So let's use finance as an example. Do you go into them simultaneously? Have you ever started with finance? Or is it really, it's the end user, make sure they're demanding, and then like it's always that way? What's the timing of this?
We've tried a lot of different ways.
Yeah.
And the reality is you've got to have a clinical champion.
Even if you know if finance is bought in, they know the cost. It's not going to happen until you have someone asking for the product.
Here's why, and I know people listening to this I know they'll start shaking their head. I promise you, apathy is king in a lot of places.
Yeah,
They just don't want to change.
yeah,
So even if you have the C-suite, I think of an example of a large community system in Florida had a significant problem, significant, millions of dollars in spend out of their pocket on this problem. We put together probably one of the finest C-level meetings I've ever put together on these. We had the entire C-suite there,
yeah,
including the CEO, which is a shocker.
yeah.
Okay. We had every director of every major department in the meeting, and we had all the quality people, everybody, probably about 15 to 20 people from their side, 6 on ours. Huge meeting, went fantastic. CEO says, CEO, we're doing this.
Yeah.
Figure out how to do it.
Yeah.
They took it down to the actual clinicians that would be on the floors doing the procedure. They fought against that so hard. They did not want to change. They did not want to learn something new. They had no interest in it. And it never started.
Wow.
And we had a huge C-suite meeting.
And is that an example? You actually started at the C-suite without getting the clinicians on board first. And they don't like to be told what to do, right?
I met I believe it was the CMO for that system at a Marcus Evans meeting, which Marcus Evans does the executive meetings. You can go to their different meetings that bring together all of them. Yeah. And the CMO said, we're doing this. You got to come. And that's how that started. So we booked a meeting and went, and he pulled together every single person, including the CEO of the hospital.
Unreal.
Never took off. Clinicians bucked it, fought it, weren't going to do it, to the point where you recognized it was not going to get a fair trial. It wouldn't happen. Well, yeah. And never happened.
You got to get the clinicians on board first.
Got to have the clinical champion.
Then you could talk to them.
That's right.
Perfect. I love it. I think we sign off there. I mean, that's really the key. It is changing things. It is getting better. You can make an impact. It's giving you additional call points, but you still got to sell the product to the end user, and then value-based contracting can really have a positive impact.
Absolutely. It's a slow burn. So if you start doing it, don't give up. We've been slogging away at this for years, and it's worth it. And you're going to change some hearts and minds with it. Not everybody's, but just keep slogging away. It's a slow burn.
Awesome. John, it's been such a pleasure talking with you. This has been so much fun. You have such a depth of experience on this, and thank you so much for doing this.
Well, I appreciate it. Thanks for having me on. I really enjoyed it.
You got it. So that's a wrap. Wow. John Maverick, thank you so much. You gave us all so much to think about, and basically a roadmap to truly partner with your customers and the right customer that makes sense to do a value-based risk share agreement. So until next time, thanks for listening to the Demanding Value Podcast.